Okay. All right. Can we see if people are on yet or?
I'll be able to see that. So I would just say you can go ahead and get started and people will come in.
Okay. All right, great. So we're here tonight to talk about concussion diagnosis from the playing field to being able to be cleared to go back to play. So we're just talking about concussion diagnosis, how we manage concussions, and how we can get you back to the playing field, back to school, back to work faster. It's a panel discussion, so we're going to present concussions from the playing field with Corey Monaco, who's the athletic trainer at Staples High School. Myself, Dr. Paul, I run Advanced Concussion Solutions. My background is in pediatrics and pediatric emergency medicine, and Rob Malman, who's a physical therapist at Performance and does a lot of the rehab work with concussion patients to help them get back to play. Before we get started, I'm just going to ask everybody to introduce themselves, talk a little bit about their background. So I'll start with you, Corey.
Perfect. Hi, everybody. So I'm Corey Monaco, like Dr. Paul said. I'm currently the head athletic trainer at Staples High School. I am in my 13th school year somehow being there. We have met before to go over this, and I'm thinking this is a great opportunity to answer a lot of questions and hopefully give some information to the parents. Some of the questions that I see a lot of, and I'm sure Dr. Paul and Rob also get a lot of as well. I've been at Staples, like I said, for 13 years. And in addition to that, I worked in high schools in New York and doing clinic outreach. And I also have my own company, which I work primarily youth sports, although I have worked with men's leagues and junior hockey leagues as well. So I've had a wide range of experience with athletics and with concussion injuries as well. So I think that's it for me.
Rob?
Yep. So I'm Rob Malman, as Audrey Paul said. I work in our Westport location. I'm the site manager of that office. Been with Performance now for almost 6 years. Started working with concussions probably about 4 or 5 years ago. I did my last clinical when I was in physical therapy school was at a Air Force base. So saw a lot of post-traumatic and traumatic brain injuries in that setting, and then took it into the sports setting. And I'm also an orthopedic clinical specialist, and then dove into more of the concussion realm, and then also scoliosis with the Schroth method. I'm mainly working around like sports and orthopedics at this time right now.
Great. And as I said before, I'm Dr. Audrey Paul. I run Advanced Concussion Solutions. I've been specializing in concussion management since 2016, and I've been practicing pediatric emergency medicine for longer than I would like to admit. My background, I trained at both Columbia Presbyterian and Mount Sinai for pediatrics and pediatric emergency medicine. And I became interested in concussion management from a personal note because my son is an ice hockey player. He's a goalie for several years, sustained several concussions. And in order to better help him, I really became interested in learning how to help parents and athletes and non-athletes recover faster from concussions. So with that, I thought I would just start with a basic introduction on concussions, what they are, some basic current diagnostic techniques that we use from concussions. And after that, I'm just going to put it out to our panelists to, just discuss some common questions that we see on the playing field or in physical therapy, or even in my office, that parents or athletes will often ask about concussions. So just to start, first of all, concussions are extremely common. About 1 to 1.2 million sport-related concussions occur each year, and about 400,000 athletes report concussions each year. And these are only reported concussions. I mean, the estimate of unreported concussions is actually much higher than that. In the pediatric emergency room, we actually see about 200,000 concussions annually. So that's a pretty high number. So everybody always wants to know what a concussion is and whether we can diagnose a concussion by a CAT scan or an MRI. So concussions are kind of an invisible diagnosis. You can't see them on a CT scan or MRI, and they're more of a functional injury rather than a structural injury, which means that in English, concussions tend to be more of an injury at the cellular level than at the structural level. So it's not like a skull fracture or a brain bleed. The definition is basically like from a cellular level, is a traumatically induced disturbance of brain function that involves a complex pathophysiologic process. And so what happens is at a cellular level is the concussed neurons are essentially get into what's called an energy crisis, because the powerhouse of the cell, the mitochondria, is dysfunctional during a concussion, and that dysfunction results in an energy crisis in the cell and then overall in the brain in terms of being able to transmit messages from neuron to neuron and from your brain to your legs, your arms, affecting your balance, your vision, your cognitive processing, emotional functioning, and a variety of other signs and symptoms that we end up seeing with concussion. As I said before, so as at a cellular level, it's caused by stretching of the cell membrane, and that stretching causes a cascade of metabolic and cellular events, and that disrupts energy metabolism, and that slows neuronal transmission. The other interesting thing is that concussions also affect blood pressure and heart rate regulation. So many patients who are concussed report feeling really dizzy when they go from lying down to standing up, or they have exercise intolerance. Athletes who normally can run 10 miles suddenly can't run even 20 minutes without getting headaches or feeling dizzy. And a lot of that has to do with the dysregulation of heart rate and blood pressure that occurs in concussed individuals. One of the big things that we've now discovered with concussions is that we used to always say every concussion is different, which it is to a certain extent, but we've now found that there are actually different classifications of concussions, and concussions certainly all have something in common with each other. So we found that there are different subtypes, and based on these subtypes, we can actually now treat concussion, which is why Rob comes into the picture. So the subtypes are vestibular, which affects balance; cognitive, which can affect mental processing; fatigue or energy level related concussions; anxiety or mood; headache or migraine; and ocular, and as well as which affects visual tracking; and then also cervicogenic, which is kind of like a whiplash injury. And these patients will have neck pain and headaches and symptoms that are basically identical to what we see with other concussions. One of the things that's important to note is that even if you didn't pass out on the playing field, you still can be concussed. Less than 10% of concussions involve loss of consciousness. And, in terms of diagnosis, and this is something that Corey can talk to about on the playing field, and I will discuss in the office, but there are a lot of diagnostic tools that we can use now to diagnose concussions. On the playing field, Corey will talk about the ones that she uses. In the office, we go through physical exam. There are new technologies that are out there available now in terms of visual tracking abilities and EEG. And so there are a lot of new things that are on the forefront in terms of helping us to diagnose and track concussions. And so what I'm going to do now is hand it over to Corey, and she can discuss some of the things that she does on the sideline and some of the questions that come up in her experience as an athletic trainer.
Great. Thank you, Dr. Paul. So one of the things that we are looking for, or I guess the main thing that comes into a concussion, is what are we looking for when the initial hit happens? So my job as the athletic trainer is I'm on that field and I am there for any injury and illness that can occur while an athlete is participating in sports. So my main concern is, what is the initial presentation of an athlete with a possible concussion? So the first thing that I'm looking for is I'm going to do a symptom screening. So if I have an athlete who has either sustained a large hit during a game, and I say large hit and not necessarily hit to the head, because I think that that's something that can be deceiving. People assume that you need to get a hit to the head in order for it to be a concussion. We've had athletes who have been hit and they fall down and they just land the wrong way, and they may not be hit directly to the head, but they still can sustain a concussive force and end up with concussion symptoms. So after an athlete has sustained a hit, or if an athlete comes off the field and we may not have even witnessed the hit and they're complaining of certain symptoms, then we're concerned about a possible head injury or concussion. So I'm going to go through a symptom screening with that athlete and see exactly what they're reporting to me. In addition to the symptoms that they report, I'm also looking for signs. So the sign is something that a practitioner sees, where a symptom is something that the athlete will report. So I'm evaluating them potentially before they even know that. So they get up off the field and they're a little wobbly, or they're off balance, or they come off the field and they're hysterically crying for what seems like no apparent reason. Could be the emotional disturbance like Dr. Paul had mentioned earlier. So these are the things that I'm looking for and that I'm going to work at initially when they first come off the field. And then we can go into more detail as the evaluation continues. So typically I will do a cranial nerve screening on an athlete and look for any abnormalities and kind of pick at what I think needs to be addressed further. So some other athletic trainers can do such things as VOMS, which is a method for eye tracking, and it's something that a lot of them will use. Some will use a SCAT test, which I know some people are familiar with, or King-Devick on the sideline. That is not something that we do at Staples or I do within my own personal practice, but these are all other options that are available to the athletic trainers to weed out a potential head injury and make sure that we are removing that athlete from play if we have a concern for a head injury. That's a common follow-up question that we get regarding the initial evaluation is baseline testing. So like I mentioned earlier, SCAT testing and the King-Devick are two very common sideline tests that can be utilized by some athletic trainers, and those require a baseline test. Similarly, a lot of people have heard about the impact test, and that also, although it doesn't require a baseline test, it's preferred. So that way we have something to compare back to. So at Staples, we do not do any baseline testing. We don't use the SCAT, we don't use King-Devick, and we don't use impact. We haven't been using these for quite some time. The only one that we ever did use was impact, and I think that dates back possibly to 2006. Not to date myself, but that's the last time I think that we've been doing any baseline testing. So at Staples, we don't do that, but I know that some other schools and programs might. And I know that some of the doctor's offices will offer that service for parents that are looking into getting their athletes baseline tested prior to being in athletics. Another issue or question that we come upon is, why do some athletes go back after they sustain a big hit and some are not allowed to go back? And the answer really is just as simple as what we went through earlier, the signs and symptoms that an athlete is presenting with. So when an athlete comes off the field and we are concerned about a potential head injury, I start going through my evaluation and I see what they present with. If an athlete at Staples has any sign or symptom, even one, they are removed from play and not allowed to return. However, if we go through an entire concussion screening, they pass without any issues, without any signs, without any symptoms. I usually will speak to the parents, I'll speak with the coaches, and I go through detailed information with the athlete in terms of what we're worried about, right? So if we have any of X, Y, and Z while we return, or if we return, we stop immediately and you're going to come back out and see me. If we go through all of that and the athlete is deemed okay, then they are returned. And on the flip side, if we go through all of that and they have any symptoms, any signs, or there's any concern of a head injury, they will be removed and referred to the doctor immediately. Once they get referred to the doctor, the next follow-up question that I get is, how long am I out for? And unfortunately, there's no simple answer for this. I wish there was, but there isn't. Every person is different and each concussion is going to be different for that person. We can have athletes who have sustained one concussion respond one way, and then they sustain not several, but follow-up concussions, unfortunately, and they will react differently to each concussion. So a lot of times they think, well, last time I was out for this long, is it going to be the same? Or last time I wasn't out as long, why is this one different? And the reality is that the body is reacting to that concussion specifically, and they have to allow themselves to heal appropriately. I wish I could give them a more clear-cut answer, but unfortunately, there's just no way to do that until we see how they're feeling and how their symptoms respond to their body for that particular concussion. With that, one of the big policies at Staples that I know gets a lot of questions from parents and the athletes as well is our concussion policy for while they're out and being allowed to attend practices on the sidelines or travel with the team. So at Staples High School, our policy is that they are not allowed to be on the sidelines. They can't travel on the bus with the team, and they can't attend practices while they have a concussion. The main reason for this is for their health and safety. And at the end of the day, that's my number one job, and my number one goal is to keep these athletes healthy and safe. We run the risk of them potentially getting hit, believe it or not, even in the most non-contact of sports, on the sidelines. If they're at practice and they're there, they could potentially get hit, and we don't want them to sustain a second hit while they're still symptomatic with a concussion. The other issue that we run into is that we have athletes who are attending these practices and games and they're still symptomatic, and this prolongs their recovery, which keeps them not only off the field, but out of the classroom. So from an academic standpoint as well, that has to be a priority. And we want to make sure that these athletes are able to heal physically, mentally, emotionally, and be able to return to their academics as well as their athletics. So although it seems like we're penalizing the athlete for having a concussion, the reality is it's to try to keep them as safe and healthy as we can and get them back on the field as quickly as possible. It is a school policy, and we have several parents that, you know, have the doctors write in the note, but they can be on the sideline. And unfortunately, it's a school policy, so that's not going to be allowed. And again, it is for their safety. And I know that it's very disheartening for the kids, but we do work with the coaches and the teams to try to involve them in other activities, such as the pasta dinners, to keep their morale up and allow them to continue to feel like they're part of the program. Once they go through all of this and they are cleared and they have to go through the return to play, that tends to be another big question for us. So what is the return to play? How long is the return to play? Why do my students have to do it? So the return to play is technically 4 days after they're cleared. They go through this progression every 24 hours. So we have to do day 1, day 2, day 3, day 4, in 4 consecutive days. So they can't do a practice in the morning and another practice in the afternoon and count that as 2 separate days. It's very clear that it needs to be 24 hours apart, and that's to allow the body to go through that and make sure that we remain sign and symptom free before we progress them to the next step. Sometimes we have athletes who are doing really well and they're sign and symptom free at rest, and then we begin them on this return to play, which increases the heart rate and can change what they're feeling. And we see that they have symptoms occur, whether it's on day 1, day 2, day 3, day 4. It can happen at any time. And whenever that does happen, we take the time, we take a step back, we have them rest, we have them go symptom free again, and then we progress them to the next step, or we repeat that step if necessary. If an athlete really struggles with the return to play, we will return them back to their doctor and make sure that they want them to continue to progress, or they may want them to take some more time to rest, or we refer them to physical therapy, or the doctor will refer them to physical therapy because there's a need for that in this particular case. The return to play is really critical and paramount to really make sure that these athletes are safe and ready to return to the field, which is obviously what our main goal is, being an athletic trainer and amongst the 3 of us, to really get these kids back on the field safely and recovered from their concussion. I think those are the main questions that I get, but if I've missed anything, if you guys want to jump in and let me know.
That is the biggest thing about, getting them back to play safely. I did have a question about that because, we do, so for, the CDC recommends a 7-day, I guess, return to play protocol, but, the first couple of days, and I often will say this, are basically, you start with just strict rest, and then, the next day you walk around the block. And so part of that, I feel like, is part of their basic recovery anyway. So it's not like, parents think that it's going to be this, it doesn't necessarily have to be this whole exactly 7-day protocol. Often it's, about 4 days, I would say, in total, from when you actually see them on the sideline. So
exactly. And I think the reason why I wanted to say 4 days is exactly what you said, is that they see this 7-day protocol and they panic because they think they're out for another week. The reality is the first 1, 2, or 3 days they've already accomplished prior to them coming to me and getting started. And typically the last day is return to competition. So at that point, not that we don't count it, but again, it's just that they've already been cleared at that point. So I try to downgrade it so that it's not as frightening for the parents or the athletes to think that it's 7 additional days. A lot of times it's the 4-day progression they need to do. And really on day 5 would be a return to competition. So.
Yeah. So, Rob, actually, from your perspective, in terms of, clearing kids to return to play, because that's something that comes up in my office as well, so how long, I mean, especially if you have an athlete who's playing contact sports like football, ice hockey, let's say they're completely asymptomatic, and, in PT, for example, or in my office, how long would you wait before actually allowing them to go into contact sports?
So it's a good question. I think one of the biggest things that Corey highlighted, just to like backtrack for one quick second, is starting activity sooner rather than later. Even if someone's asymptomatic, we just have to go through the proper return to sport protocol. But even if they are mildly symptomatic, because there is research out that shows starting light aerobic activity 24 to 48 hours after concussion, while it's still manageable and symptoms aren't too high, actually helps improve prognosis in those first 14 days. So getting active sooner rather than later. Now, what I would want to highlight is it's not, hey, jump on the bike, do, a 60-minute Peloton ride a day after getting a concussion. No, but like what Dr. Paul said is going for walks, staying active, not staying in a room, not avoiding things is actually really good. You want to get stimulus and just manage symptoms. What I tell people in the office sometimes is let symptoms get to a 5 or 6 out of 10. When they start to get unbearable, remove that stimulus. You don't want to completely, what we used to call like cocoon from things, because that actually delays people from progressing. And then to Dr. Paul's question, actually makes it harder for someone to get asymptomatic to where we actually do fun stuff in the clinic. So to Corey's point, she'll run people through treadmill tests, exertional tests, which we'll run people through as well. Ultimately, Corey and Dr. Paul, they're the ones that are going to give the stamp of approval to go back to the sport. What we're going to then tell Corey and Dr. Paul is, all right, this is what we had them do in the clinic in a controlled environment that recreates what they need to do in that sport. So specifically for football, what we'll start off with is, depending on their position, agility and aerobic drills, making sure they can cut, pivot, and twist and turn quickly and accurately while asymptomatic, and not putting them at risk for one, getting hit negatively and causing another concussion, or God forbid, another injury. Reaction time drills, dual tasking. So even doing, let's say, something as simple as like ladder drills, but while telling me the months backwards, or counting up or down by 3s or 4s or 7s. So making them cognitively focus on something while motor control something else, and then coordinate through that. Get them to a fatigued state and do that, because we all know at the end of a game, when everyone's tired, that's when things can also go haywire. So we want to push them to that point as well. Sometimes it's through their session, they're doing the sled up and down, getting their heart rate up. To Corey's point of the exertion, what we'll usually do in our examinations is either the first day or the second day, we'll actually run people through an exertion test and see what we can get their heart rate to. So we'll do, let's say, a simple equation of 220 minus their age to get a rough idea of the max heart rate they can do. And we'll usually push people to about 80% of that on a treadmill test or on a bike test. And we'll track their heart rate either by a chest strap or a pulse oximeter that also looks at the heart rate, or by the little sensors that are on the bike. And then from there, basically tell the patient, one, where do you start to feel symptoms? And we're going to live below that threshold. Or if you don't get symptoms, we're just going to try and see how your heart rate responds. And that we'll get into when I talk a little bit more about like different types of concussions that we treat. I can talk a little bit more about that. But specifically to football players, we're going through all of that, and then actually to some extent getting contact going on. So what we've had people do is actually like taking pads, and when I say pads, it's like pads that you would do like box jumps on, right? And actually go into, let's say, a 3-point stance, depending on their position, and push into that pad, or do activities where they're pushing into a wall and just getting used to an abrupt force, not hitting their head or anything abrupt, but actually being able to work into that and see how they respond to it. Because the other part of it too is the fear of getting hit again, and making sure that they feel comfortable. I've also even talked with coaches too of when they do start to progress back to sport, it's usually not in a game setting or a practice or a scrimmage setting. They're starting with non-contact practice, get used to being back with the team, people running around them, things happening. Then light contact practice, maybe with their helmet only. Then it's where, all right, now it's actually getting to contact, but it's usually one-on-one. You're not running plays yet. So you're actually seeing, all right, how do I perform against one person, blocking, cutting, pivoting, and then, all right, now let's actually run through plays. Make sure you can do that. I usually tell people 2 or 3 practices and then progressing forward. But that's also in communication with the athletic trainer and the physician that's helping manage that as well. So in a timeline with that, it could vary. Some kids, it's a couple sessions. Others, it could be a couple weeks. What we also sometimes notice is some people are really deconditioned. And while it's all right, yeah, you're fine concussion wise, but you actually need training and actually sport conditioning to be just a better athlete. And we can highlight that sometimes with what we're looking at.
Have you noticed actually that concussion patients, when you do that kind of exertional, what we call the Buffalo treadmill test, actually, that they have higher resting heart rates when they, oh, you're glitching out.
I can still hear you. Don't worry. My Zoom's just
Yeah.
glitching. Don't worry. I'm still.
Okay.
So what I have noticed, which is actually interesting, is both a higher resting heart rate. So let's say an average resting heart rate, anywhere can be from anywhere from 60 to 100 beats per minute, but let's say it's around 60 to 70. Usually, especially for a kid, it's usually around that. Sometimes what we'll see is an elevated heart rate to start. Now, one part you can think is people are stressed. I'm running through a test. I'm at like a PT's office or doctor's office. Like this is nerve-wracking. Right.
Mhm.
So what we'll usually try and do is let them calm down, see how they are symptomatic wise. And then with the treadmill test, what we'll actually do is every minute we increase the grade, or with a bike, we increase the resistance of that activity. And what we see is RPE, so rating of perceived exertion. So how hard do you perceive it actually is? We track your heart rate, look at blood pressure pre and post, and then throughout that also track your symptoms. So say I have a concussion, I'm starting resting heart rate at 60 beats per minute. I have just a headache at a 3 out of 10, and we start the test. Over time, right now it's it's a 0 in my RPE. If I get to a 7 or an 8, that means I'm maximally pushing someone pretty hard. That is usually when we'll stop it. Or their symptoms will increase by a 3 out of 10 or more. So if I start at a 3, once they get to a 6, I'm cutting it. Or the heart rate reaches their max. And that's where that 220 minus the age comes in. What we'll see a lot with concussions, especially if it's an autonomic concussion, so the autonomic nervous system is affected, is either they'll have a higher resting heart rate. What we also sometimes notice is that their heart rate will elevate normally, but then it will actually dip for a couple minutes and then go back up. So it won't be as much of a linear progression as it normally should be when any of us are exercising. We'll actually see that heart rate go down sometimes within it. And that will then cue us where, all right, we have to use aerobic activity to get this person, one, conditioned, but two, help reset their autonomic nervous system. Same thing will even happen with even ocular or vestibular exercises. Sometimes people's heart rates will elevate during that.
Yeah, I've seen
when
that.
you're at rest, right? So
Yeah.
that shouldn't technically cause your heart rate to elevate, but that's where the stress component on the body comes in. And that's even why too, like a lot of people think just activity elevates your heart rate, but there's a lot of different ways to stress the body that we can kind of tap into that will also assist with that.
And so what kind of treatments do you do, like within physical therapy for concussed kids?
Yeah. So I would say the easiest one is, say someone comes in with a cervicogenic concussion, right? So very mild symptoms, maybe a light headache, a little bit of dizziness, and mainly their chief complaint is neck pain. So usually for that, we're doing some manual therapy to relax some of the muscles of the upper cervical spine, so right at the base of the skull, which usually is causing the headache that someone will feel, let's say in the front of the head, the orbits of the eyes, or even around the sides, almost like a ram horn type position. That's the easy one there. And then from there, we're working on postural strengthening of some scapular muscles, some deep neck flexor muscles, and then gradually ramping back up into activity. Where it gets a little bit trickier is when you start to look at the vestibular or the ocular concussion. So vestibular, what I kind of tell people is think of like 2 carpenter's levels in each ear. And what they do is they give your body an idea of how you are balanced in space, both horizontally and vertically. And what can happen after a concussion is, due to where the vestibular nuclei are in the brainstem, it can actually throw off how your vestibular system functions and make it a little haywire. So people will have balance deficits. They might even also have altered sleep and feel a little bit more tired in the morning, or a little bit of insomnia later on. And what we'll work on with that is a little bit of balance. We'll actually bring in their cervical spine and work through there, just because of the close proximity that this upper cervical spine has to that area in the brainstem. Kind of almost hits the reset button a little bit. And then also retraining them with different tasks that make their vestibular system have to work. So things like standing on an unstable surface with their eyes closed, their eyes open, having to balance on different surfaces, do different tasks, catching balls, moving through different things in that regard. Then when it comes to more of the ocular, that's when like the weird eye charts that people always see comes out. So we'll do things like different checkerboards behind, or different backgrounds, and then people having to follow their eye as they're moving, or follow different targets. What we'll also sometimes do is take a laser pointer, and you'll have to follow the target with the laser pointer. All of that time, we're looking at how do your symptoms respond? Do they kick up? Do they not? Corey highlighted VOMS, like so the vestibular ocular motor assessment. So what we're looking at with that is, and I'll do that in my evaluation, do any of those specific tests kick up your symptoms? That becomes a treatment. So it actually makes my job super simple, where literally what bothers your symptoms now becomes treatment. And then I progress it, make it harder over time to the point where you actually don't have symptoms with it anymore, because we're actually building up your tolerance to it. One of the toughest ones is the autonomic, which we just kind of talked about. And that's when people have that irregular heart rhythm. Sometimes they also will have a little bit of change in personality or even mood swings, which are a little bit harder to deal with. And sleep is actually one of the biggest difficulties with them, I've found. So a lot of it is just kind of coaching healthy practices with sleep, trying to decrease screen time closer to when you're falling asleep and keep consistent times. And they usually have some of the biggest struggles with actually not even return to sport, but return to learn. So actually, like, one thing we're kind of talking about a lot more is like return to sport, but now actually returning to school and sitting in class and reading and stuff. That's where a lot of the vestibular, ocular, and autonomic things can kind of play in a little bit further.
Yeah, no, that's I think with my patients, that I have in my office, that's often the most challenging. And I find, they do say, I mean, at least if you look in the literature, patients who present with the patients that I see, actually, the ones who have difficulty with visual tracking, and also will sometimes have what we call convergence insufficiency, which means that they will see double, like with, less than, when your hand is like almost in front of your face. So that makes it really challenging to read. And those symptoms seem to take the longest to treat. Unfortunately, people often ask if there's any, medications that you can use to treat concussions, make concussions heal faster. Unfortunately, the only real way to treat concussions are through, active recovery, through physical therapy, through, light, what I call subthreshold exercise, which is exercise that you do, before you start kicking up your symptoms, and just, and proper nutrition and time. And there are different medications that I will use in my office. Some patients will experience what we call chronic post-traumatic headaches. So you can use certain medications to treat those headaches. But generally speaking, they don't accelerate the concussion recovery. They just maybe, things are,
Don't worry.
yeah. Otherwise, those symptoms will, and so it makes it more bearable during the time that you're recovering from your concussion, but they don't make the concussion recovery any faster than without medications. As we were talking about with sleep, some patients will suffer from extreme insomnia from concussions. And in those very rare cases, we will use medication to help with, reset their sleep-wake cycle. But generally speaking, I tend to recommend basically, melatonin an hour before bed. And as you were saying, like practicing really good sleep hygiene. So I would say in terms of, one of the most common questions that I get, especially because I do tend to see kids who come in who've had multiple concussions. And so, the question is like, how many concussions are too many concussions? And so I don't know, Corey or Rob, like how you feel about this in terms of what your number threshold is. What do you guys think?
Personally, I defer to the doctors who are treating the athletes, to be honest with you. I never like to give a hard, fast rule because I think it can put you into a box. I think each kid and each athlete is different. And you could have one really severe concussion and that could be the end of your career, or you could have several and, be able to recover well from them and be healthy still. So I don't have a hard, fast rule. I think it comes down to the doctors treating the athlete, potentially the physical therapists who are treating the athlete, and the families and their personal opinions, and the type of concussion that the athlete sustained and what their recovery road actually looked like for them, both, again, academically and athletically. Like, I know we've all been touching on the athletic component, but the academic is huge as well, because sometimes we might have an athlete who feels well and wants to return to the field, but they're really still struggling in the classroom. And that's still something that needs to be addressed as well. So I don't have a hard, fast rule. I don't know, Rob, if you have one, but.
I would say, to go off of that, I don't necessarily have a hard, fast rule of the number of concussions. If I were to put a number to it, I've seen people sometimes with 5 or 6 concussions. I've seen people with 2 concussions. Sometimes the person with the 6th concussion is actually not as bad as the person with the 2nd concussion. So to Corey's point, it really does vary. If someone has had repeated concussions, sometimes what I will say to them very candidly is, if you're having this many concussions playing this sport, something's wrong. You're not moving properly, or you're getting hit a little bit too much. There's a little bit of susceptibility depending on the sport. So it might be a little bit thinking of, is this the right sport for you? But to echo what Corey said, it really is person specific, family specific. It's a decision that everyone needs to make. The whole medical team with the family and that student athlete, that's really where it comes down to. My opinion is it's not 3 and that's it, but it really would be, it's all right, you had 1. If the second one's worse than the first one, we got to be careful. If the third one's now even worse and the symptoms are lasting much longer, for example, let's say I've seen them for a concussion, 2 weeks in and out, they're good. And then the next one took about 6 weeks for them to get a little better. The third one, it's now 6 months. And that's where it's like, okay, this is not on the trajectory that we really like. We should probably kind of have a backup plan. Or so we want to go that route of. And Dr. Paul and I've had concussions or conversations with parents on that before. Most of them go really well because it's almost like the writing's on the wall almost.
Yeah.
And what her and I will both kind of agree with, and Corey, I'm sure you do the same thing, is it's all education. Like my first session with people, it's an hour long. We're running through everything comprehensive, looking at all the stuff that, we need to understand the concussion, but then it's educating what a concussion is, what a timeline I expect to see, and what I'd want to see week by week to know that we're on the right trajectory. And what I really try and make sure of is I know what everyone's doing outside of here. Because to Corey's point, if someone's working really hard at school, and then when they're in the clinic, I'm able to do certain things, but then they're still coming back flared up. And I don't know that they're maybe studying for their SAT or they're working with a tutor, right? That's going to then throw things off and make something a little bit harder. So there's a lot of variables into the mix. There's no perfect answer. What I would more say is it's just how severe symptoms are, how long does it take, and risk versus reward.
Yeah, no, I agree. I think it really depends on the individual patient. So I've had kids who've taken 8-9 months to recover from their concussions, and that's one concussion. And to me, that's one concussion too many. It's just not worth, it's a risk reward kind of thing. So, in those cases, I think, there's no guarantee that just because you don't play contact sports, you're not going to get concussed again. But I feel like in those situations, it's worth it to mitigate risk and probably not play something where you're putting your brain in the fold, then again, there are kids who've had a number of concussions where you start noticing cognitive differences. If there's any impact on cognitive function as well, I tend to become more concerned with that. A lot of people will say if they've had 3 concussions, it's like 3 strikes, you're out. What I say to that is it depends a lot on timing also. So if you've had 3 concussions over 5 years, and each concussion was like, one concussion was 2 years ago, the next one was a year ago, and they've had pretty rapid recoveries from each one. I think in those cases 3 doesn't really matter. If they've had 3 concussions in 6 months, that's kind of a different story. So it depends on the number. It depends on like the time period over which those concussions have occurred, as well as like how long their recovery is. And that being said, so that's a big question that I get asked in the office. Like, so when am I going to get better? Right. Because it's kind of nice, if you have strep and you take your antibiotics, 24 hours later, strep is gone. It's pretty clear cut. Concussions are much more fuzzy. On average, they say like people who are, 18 and over, who don't have a history of concussions or other comorbidities like migraines or, high anxiety levels, they tend to recover within about, 10 days, I would say on average. But, things that, can affect your recovery time, being female, being, a teenager can definitely make things take longer to recover from. And actually, the interesting thing is the younger you are, the longer it takes to recover. So if I have a 10-year-old coming into my office, Corey, you probably don't see a lot of those kids. Like
They use football. I got my little youth kiddos.
Oh, okay. Yeah. So,
Yep.
so they tend to, on average, I would say they take 3 to 4 weeks to recover. And so when parents will come up to me and say, well, my kid still having headaches 2 weeks in, and they start to get really concerned, I said, they will feel kind of off for about 3 to 4 weeks. So you shouldn't worry about it. It's just, that's their timeline for recovery. Other things that can increase recovery time, as I said, I guess not really recognizing and treating a concussion in a timely manner. So I think one of the most frustrating things about my practice are when, people come to see me and, they got concussed, they rested for a day, but then they went like basically fully back to school, did everything they were, tried to kind of like muscle through school, full school days, full workload, no treatment at all. And they come in like 4 or 5 months later and, they're a mess. And, if you can get these patients in really, the sooner I can see them, the better off they seem to do. So if you can start early treatment, they tend to have a much better prognosis.
I think off of that point, Audrey, literally what we were just saying too, like timelines between concussions, when they're addressed as soon as possible, and then the timeline's appropriate to keep someone off the field, gradually progress them, that usually helps provide a good buffer for risk of another concussion. And then that just helps mitigate it down the line. We've even seen people come in direct access from a concussion where I'll reach out to Dr. Paul and say, hey, I have someone, need you to see them, and she'll get them in right away. And that's where it's just trying to get that continuum to keep moving. Because ultimately it's up to a physician to, clear them and guide them. And then Corey being in the athletic training room, like she's going to then clear them onto that sport if they're in high school or wherever she is at. Like I don't have the ability to clear or to solely treat someone. They need that extra guidance. And I think getting that sooner rather than later, like we promote that, no matter who it is, but really trying to make sure that they're getting treated as fast as possible. That's the most important thing.
And the other thing about clearance is that, we have, Corey, you had mentioned this, like you will see kids who sometimes, can't get in to see somebody. So they go to urgent care to get cleared from their concussion. Or, they get like a note from, they talk to their physician on the phone. Oh, I feel better. Can you clear me now? So actually, proper clearance actually does take, it's not just like going through a symptom checklist and saying you feel fine. I mean, I've had kids come into my office who are like, well, I'm ready to go back now. I'm better, and then, we start doing like all the provocative, testing with, visual testing, exercise testing, everything else. And, oh, guess what? Like, oh, well, actually, I have a headache now. So in those cases, they're actually not clear. And, you don't want to prematurely clear somebody, because if they're still concussed, they are at higher risk for getting a second injury. And if you're concussed, if you sustain another concussion while you're actually concussed, that increases your recovery time substantially. So that's something we really try to avoid. I mean, kids who are returned to play too soon or play while they're still concussed, or even like they have a fivefold higher risk of getting orthopedic injuries because their coordination and reaction time are off. And also they're just at higher risk of getting concussed again. So it's really important. I always tell kids it's better to miss a game than the whole season. It's just better to wait, make sure that you're fully better before you get back on the playing field. The other question that I do get asked quite often, and I would say that probably once a week, maybe, is, especially in kids who've had multiple concussions or kids who are more concerned, am I going to get CTE? Chronic traumatic encephalopathy. So, because obviously that's been a big thing that's come up now, especially in the NFL, the NHL, and it's something on everybody's mind. First of all, it's actually been very difficult to actually discern, what's going to definitively cause CTE. Like nobody's actually been able to find, that magic number of concussions that you have to have that's suddenly going to exponentially increase your risk of developing dementia and CTE later on in life. What the thought is that the mechanism has to do not so much with concussive hits, but subconcussive blows. So if you're somebody who's been playing football since the age of like 5 and you just getting repetitively hit in the head, or you've been heading a soccer ball and now you're a professional soccer player and you just have those hits, like 50 hits a day, every single day since the age of 5, those individuals are much more likely to go on to develop CTE. But, if you've had 2 concussions, that doesn't, I don't think that necessarily makes you at any higher risk for developing any issues later on in life. So.
I've had kids ask that at my office as well, because it's just like you said, it's a hot topic and the kids hear about it in the NFL and the NHL, and then that becomes a concern for them as well. So I've tried to explain the same thing to them and the subconcussive hits and explain the difference. So that way, to try to motivate them to really be honest and be aware of what they're feeling and when they're feeling it. And that way we can address things sooner than later. But it's interesting that they ask you that as well in the office, that that's still a concern. Yep.
Yeah, so the no, it's definitely out there. And I guess the
Mhm.
last thing I'll say before I'll just open up to any questions in the audience is I always get the question about like if there's anything that I can buy like to keep my kid from getting concussed, you know. So currently, you know, there are certain device. First of all, I mean, there are devices on the market like the Q collar, for example, which I've been asked about actually maybe about once a week, you know, whether parents should buy a Q collar. I mean, right now, I don't think I could really fully recommend use of the Q collar just based on, you know, and I've asked people who are like emergency medicine physicians, pediatricians, you know, it's just the risk of like, because it acts by trying to increase intracranial pressure, like pressure in your brain by compressing your jugular so that, you know, you're like a balloon. So that gives you your brain a cushion so it doesn't like slosh around and just get, you know, injured hitting one side of your skull or the other. But the problem with, I just don't like the idea of anything blocking blood flow to your brain and causing increases in intracranial pressure. I think our bodies are designed a certain way. Anything that sort of messes with intracranial pressure is probably not a great idea inherently. So I think I would want to wait to see more data before like fully recommending the use of the Q collar. But
Off that, one thing I would add to, like, I think Q collar, you know, it has some literature out there, but exactly what Dr. Paul said, like, do you really want to acute the blood flow? I would almost, biggest preventative thing I think of is like hitting mechanics and coaches teaching kids that, especially in like ice hockey, football, knowing, all right, you know, where the helmet should be, how to hit properly. That is probably going to be one of the biggest things to help decrease the risk, is just good hitting mechanics, understanding how to hit, how to set yourself up, and leading to that. And that not only will lead to less concussions, but also probably more appropriate, less orthopedic injuries as well.
Right.
Yeah.
And I was going to say that, sorry, the only other thing I can think of, and this seems so generic and basic when we talk about this, but a mouth guard, a proper fitting mouth guard. I still have athletes that come out and they're chewing on their mouth guard and it's like a piece of plastic and it's doing nothing. But if you have a well-fitted mouth guard for really any sport, I mean, I've seen basketball players wearing mouth guards at this point. My hockey players, it goes without saying that you can get hit, you know, and have teeth injuries, right? Mouth injuries. However, that mouth guard, when it's fitted properly, it protects that impact that some athletes get. We've seen athletes that can get a pretty good impact to the jaw. And because they had their mouth guard in, really protected their head and potential concussion injury. Where I've seen on the flip side, those athletes with chewed down or they put tape in their mouth or whatever they do. And then they get a hit and they can't understand why they, you know, why do I have a headache? I don't feel well. You didn't have the proper protection. So I think a well-fitted, properly fitted and functioning mouth guard might be the one piece of equipment that I would recommend in terms of utilizing for possible prevention of a head injury.
I think, yeah, mouth guards are great for preventing dental injuries,
Mhm.
definitely. For sure.
Oh,
Having
yeah.
a lot of missing teeth. So I
I've
always
had,
tell,
yep.
like great, you know, honestly, I mean, I will always tell parents like you should get your child like properly fitting equipment, you know, properly fitted helmets and mouth guards, because they do prevent, you know, helmets, while they don't prevent concussions, definitely prevent more serious traumatic brain injuries. And the same thing with mouth guards, like maybe they won't prevent a concussion, but they'll absolutely prevent, you know, serious dental injuries and save you a lot of money at the orthodontist. So all those, yeah. So those things are, and, you know, to your point, Rob, I think this year, you know, because this was the first open year after COVID, everybody tried every sport, which I think is great. I love to see kids out there being active, but I do think a lot of kids who didn't have experience in certain sports like football or, you know, soccer, or, you know, ended up seeing much higher numbers of concussions because these kids didn't grow up understanding the mechanics of how to properly play football. And so I think that proper sportsmanship actually is probably the most critical preventative tool to prevent, you know, for concussions. So if anybody has any questions, be happy to take any questions from the audience, or I know we're a pretty small group, so we're informal if anybody wants to ask anything. Nope. All right, well, this was a really great opportunity. You can reach out to any of us. I think have emails and contact information. Happy to answer any questions later offline. But thank you so much, Westport Library, for allowing us to have this opportunity.
Thank you all very much.
Yeah, thank you.
Thank you all for coming.
Thanks. Bye-bye.
Bye, everyone.